Sure, sir. I hit.
Okay, welcome everybody. We are excited again to hold another tumor section webinar as part of our webinar series. This is an exciting webinar. We have a world-renowned neurosurgical oncologist, Dr. Duffau, but I want to thank the AANS once again for their hard work with helping us with these tumor section webinars. This will be recorded, so for those who cannot attend today, this will be part of our tumor section webinar and the AANS webinar. I'd like to thank Maria Nur Ulhuda, who has been instrumental in helping me with these particular webinars, and I'd like Maria to introduce our speaker today. Thank you very much.
Thank you very much, sir, for your very kind remarks. Thank you very much, Professor Duffau, for your very kind acceptance of delivering your lecture, for sparing your time. I'm Dr. Nurhuda Maria, currently the co-chair of the Education and the Communication Committee of the ANS CNS Joint Section for Tumors. It's an honor to help in this very amazing webinar series. I'm so much pleased to welcome Professor Hugues Duffau today, and he does not need an introduction. He's such a renowned name, and I know that most of us, the majority of us, are huge fans of his work. But for the sake of formality, Professor Hugues Duffau is the professor of neurological surgery at Mount Peliac University in France, and he has got a wide, he has got immense contributions in the field of brain tumors. We all know his work on especially for low-grade gliomas and everything that he has done so far. So it's an honor to welcome him here today, sir. Thank you very, very much for spending your time on this Friday morning, and especially as the weekend is approaching. Thank you very much for sparing time from your very busy schedule. The podium is all yours now.
Many thanks again for your invitation and giving me this new opportunity to show my new results regarding surgery for low-grade glioma patients based on almost 28-year-old, now 28 years of experience in this field, and also to better understand the interactions between oncology, especially for surgeons, but also neuroscience. Indeed, I published recently a paper in Lancet Neurology showing the evolution of the concept of neuro-oncology this past decades. And when I started 30 years ago, the goal was to say we will try to remove a tumor mass. And we thought that there was an impact to the brain just around the tumor with mass effect, and that's it. And in fact, we understood that speaking about diffuse gliomas, it was a much more infiltrative disease, especially along the white matter tracts, but also with an impact on the full connectome, speaking about both hemispheres, and that we had to take into consideration the new equilibrium between networks in order to elaborate an individualized therapeutic strategy. And more specifically for surgeons, tumor mass does not exist in diffuse gliomas. So we developed the concept of supratotorization because we understood very clearly that if you would like just to remove the core of the tumor, you will not change radically natural history of the disease. But if you could remove margin away from what you can see on the preoperative MRI, including using the new sequences, then you had a chance really to increase very significantly the median survival, as you will see. And to adapt this concept, namely to remove the brain self-invaded by chronic disease, we have definitely to burn the concept of localizationism because the brain is not organized in some areas corresponding to some specific functions. Indeed, we started to learn this connectomic organization of the brain already 20 years ago. And you can see here, not a very new slide, but very exciting because 18 years ago, we demonstrated that by comparing healthy volunteers with patients harboring a tumor within the so-called SMA area, then the connectivity between the SMA and the premotor cortex was not the same before any treatment, while patients were able to have exactly the same performance score. So showing a reorganization by increasing the recruitment of the contralateral hemisphere. And this is the reason why it's possible to do supratotal resection. But what we have to better understand too, it is what happened when we diagnose the tumor in a patient, in the vast majority of cases, experiencing a seizure and with the diagnosis of low-grade glioma. And we have the feeling as a surgeon that we will go to the OR and that the day zero is when we are doing this diagnosis and when we are doing surgery. Well, in fact, we have to understand what happened in the years before surgery in order to better capture how the connectome reorganized due to this modification between the glioma growth and migration and the meta-network of networks, explaining why if you have two patients with the same tumor in the same location, the surgery is not similar because the brain is really unique for each patient. And this is the reason why we started 30 years ago, almost, to do very extensive resection within so-called eloquent areas, like here involving Broca's area, without any consequence, because the brain reorganized before, and we started to understand mechanisms of neuroplasticity. And in parallel, as a neuroscientist, we proposed new model of brain organization published in journals like physiological reviews, I mean, beyond surgery, beyond neuro-oncology, and beyond medicine, because this is the backbone of the physiology in humans, and definitely burning the concept of localizationism. I'm sure about that because I operated on more than 1,000 patients within so-called eloquent areas, and they are well in 99% of cases. So this is a new paper published in Lancet just 1 month ago, with, for the first time in the literature, more than 20 years of median survival, and with preservation of quality of life for at least 15 years. So that means that we can really change radically natural history of the disease by offering 15 more years of normal life in the vast majority of patients with low-grade glioma if you are doing an early and maximal resection, but maximal resection adapted to the connectome of each individual when we met the patient for the first time. Indeed, the goal is to operate earlier. Everyone understood that in low-grade glioma and not wait and see attitude, but also, once again, maximal resection does not mean to be guided by the imaging, because the imaging is not the disease, but guided by the connectome. And the connectome in this given patient at that time, because if we arrived 1 year earlier or 1 year later, the connectome changed in the meantime. I will not insist on the fact that if left untreated, low-grade glioma will become malignant and will induce a decline of the functions in approximately 5 years and will kill the patient in 6 to 7 years. Everyone understood that. But I will insist on the fact that if you are not doing cognitive assessment before and after each treatment, and I know that it was not done today in 2024, in 90% of departments in the world, then you understood nothing about how to treat this patient by thinking 20 years in advance and not just 3 years in advance or 3 months. I would like for the patient to recover in 3 months, and after that, I will refer him, her to neuro-oncologist, and we will see what will happen. No. I continued prospectively to follow my patient since the beginning of my career 28 years ago. And what I understood is that the limitation of neuroplasticity is not related to the lobar location tumor within Wernicke's Broca's area, blah, blah, which does not exist because it's a network. But when the tumor is migrating along the white matter tract, because if you have too much invasion of the connectivity, then you will have a decline of the cognitive functions. By understanding that, I really insist on the fact that we have to take into consideration of the inter-individual and the tumor-functional variability. Everyone will say, we have understood. No, because once again, if the tumor is located within the similar area with the same volume, the same molecular pattern for two different patients, from Monday to Tuesday, you should have a total different surgery because the brain around is not similar. And the vast majority of neurosurgeons, I know, have not understood that. And this is the reason why they have not 20 years of median survival, which is definitely unique in the full literature about low-grade glioma. Why? Because I do not use technology like fMRI or DTI into the operating theater, because DTI is not a function, because fMRI will not tell you, yes, I can remove this activation visible on the preoperative imaging or not, because critical for the function or not. Intrinsically, it's impossible with this methodology. It's not my view. This is a fact. Like this is a fact that DTI is not the function, just movement of water molecules. So it's just a quantic jump to say, oh, this is the function at the level of the red fiber, and I have to stop here. No, we know nothing about that. And I can claim that because I am a part of the International Society of Tractography, so dealing with the most beautiful expert, most really technician expert in this field today in the world. And they are the first to say, do not believe, do not rely on DTI to operate a patient at the individual level, because simply this is not the truth. Of course, it will depend on the mathematics, the biomathematical models behind. And if you think that you can operate thanks to neuronavigation and according to the preoperative DTI, never, your patients will live more than 20 years, never. Because since 30 years, I asked to the brain, this patient at that time to guide me by doing awake mapping, cortical and subcortical stimulation, but also intraoperative cognitive assessment in real time. And then we adapted the tasks according to the lifestyle of the patient, according to the job, the hobby, and so on, but also according to the culture of the patient. Why? Because, as you can see, the vast majority of my patients are coming not from Montpellier, but from other cities in France, in Europe, in the world, the 5 continents. Why? Because they were deemed as inoperable by many neurosurgeons still under the weight of localizationism or DTI fMRI, by telling to the patient, oh no, this is in Broca's area, I cannot write you, otherwise you will be aphasic. Of course not. They understood nothing about brain. And I can say that because I spent my life to operate patients not selected for surgery by others. Why? Why? Because they cannot accept these dynamics within and between networks. But you are young neurosurgeons. If you have not understood the dynamics of the circuitry of the brain, you cannot be a neurosurgeon. So I will insist on these new slides because these new results, because more than 20 years of survival with preservation of the quality of life, that the best oncological and functional results ever published in the literature about low-grade glioma have been obtained without technology, no DTI, no fMRI, no neurovigilation, no robot, no intraoperative MRI, no, and so on and so on, no microscope. So my first message for the young generation is that technology is the tree hiding the forest. If you are dependent on the technology, you will not be in agreement with the state of the art, because never you will give this chance to the patient to live longer and better. It's just the psychotherapy of neurosurgeons. How I know it? Because I ask to the brain to guide me. So during surgery, I ask to each patient to do many things simultaneously. Multitasking, the real life, when you would like to work, for instance, is to move, to speak, to understand, to self-evaluate, to perceive the emotions of others simultaneously and not in isolation. And of course, I ask the patient to continue to do all tasks simultaneously adapted to his wishes or wishes throughout the resection. And finally, when in the end I will stimulate the cortical and subcortical connectivity, then the patient will stop, because I am to the contact of the pathways critical for the connectivity within the connectome. And at that time, as you will see, the patient will block movement, language simultaneously. You have to stop. Even if you have just an increase of the reaction time, I mean, the patient should move, name, self-evaluate, and so on every 5 seconds. If suddenly you have more than 5 seconds, you know that the patient has all risks not to return to work. Therefore, you are telling me that you can judge intraoperatively if a patient will return to work. My answer is yes. And if I can do it, you should do it too. Because I am also a neuroscientist. It's not forbidden as a neurosurgeon. And I published papers showing to neuroscientists how the brain is dealing. And how I know that? Because I am within the brain since 30 years. I am an observer of the brain, but also its dynamics. So what we demonstrated that, of course, Broca's area is not the area of language. Everyone will say, yes, yes, but in fact, when you will see a patient with a tumor within so-called Broca's area, you will say, oh, it's too dangerous. The patient is young. She will be aphasic after my surgery. I would prefer just to do a biopsy. No. And it's true in France. It's true in China. Of course, you can apply this concept to all functions. What kind of function you would like to deal with into the order for? It depends on the patient. So if you are a mathematician, then calculation. If you are a lawyer, judgment. If you are a writer, syntax, and so on and so on, in addition to moving, speaking, self-evaluating. And of course, preservation of of course, the personality, the emotion and behavior of human beings. We do not care, especially if they should live for 20 years. It's not important for you to be yourself for the next 20 years. If it's true for you, it should be true for your patients, but nobody cares. Why? Because if you are doing too many tasks into the OR, of course, you will leave more tumor. Really? Please explain to me why my patients are living more than 20 years. Because I preserve the function. And how I can do it? Because I know the functional anatomy. And how I learn that by doing dissection. Of course, by using DTI, but not into the OR before and after surgery in order to better understand mechanisms of neuroplasticity. And because during surgery, I did stimulation, but also intraoperative cognitive monitoring in real time. Speaking about movement, of course, everyone understood that if you cut the pyramidal pathways, patient will be hemiplegic. Okay. Is it enough? No. If you are a pianist, I operated on recently a pianist, and he told me I need a fine bimanual coordination. Then you have to understand that beyond the corona radiata with the pyramidal pathways, you have to preserve the frontostriatal tract. And when you will stimulate, the patient will stop to move. How do you want to know it under general anesthesia? Simply, you cannot. You can avoid an SMA syndrome, but therefore you know that everyone can recover after a SMA syndrome. Are you sure? Are you sure that when we are speaking about complex movement, you will recover? The answer is no. So you decided that because the patient is not hemiplegic anymore after 10 days, then he recovered. No. It depends on the FST, the fat, but also the somatosensory reentry. So how do you want to operate in the so-called right non-dominant hemisphere if you are not mapping the sensitivity and the bodily awareness, especially if you love sports, for instance, and if you would like to swim or to run with a high level. This is critical for the next 20 years for some patients. So recently, we modeled the concept of cognition, the intention of complex action, which is much more than to avoid hemiplegia. My patients are not hemiplegic, of course, but this is not enough in order to enjoy a perfect normal life. And we have to understand the interactions between movement and moving by speaking, but also language. And I hope you can understand me. So that means that it's beyond just speech and movement and everything all together. So you have to preserve the fact. When you stimulate the fibers in the depth between the SMA and the ventral premotor cortex and not Broca's area, then the patient will have stuttering. You have to stop. Everyone knows the arcuate fasciculus and the role, of course, in articulation and phonological processing and repetition. Are you sure how it has been possible for us to publish just 2 years ago in Brain, the first journal of neurology, the functional anatomy of the arcuate fasciculus revisited, simply because no one knows the functional anatomy of the arcuate fasciculus. How do you want to apply the brain if we understood nothing about the connectivity underpinned by this very famous pathway? This is true for the ventral semantic pathway. Who knows exactly the functional anatomy of the inferior frontooccipital fasciculus? It's involved in semantic processing. Of course, I know it. I wrote that 20 years ago. But today, we have nonetheless paper in revision in Brain regarding the functional anatomy of the different layers of the ventral semantic pathway. So that means that, in fact, we do not know the anatomy today. Once again, how do you want to operate the brain without knowing the anatomy? Thanks to the DTI and Brain Lab. But it was programmed by people who doesn't know the anatomy. So it's wrong. If you stimulate the ventral and dorsal pathway, you will not induce semantic plus phonemic paraphagia. You will induce something else, jargonophagia. Please ask to the DTI to give you this information. Why, for me, it's very easy. I stimulate both fasciculi, and suddenly I have something very specific telling me, okay, you have to stop now. But there is a residue of tumor Dufault. Of course, I will not cut pathways in order to induce a severe permanent deficit to the patient. You have to know that the inferior longitudinal fasciculus, even anteriorly, can induce a lexical retrieval deficit, especially an increase of the reaction time. You tell me we do not care. Really? You remember what we said? It's directly correlated to the return to work. Yes, but maybe the patient doesn't care. Okay, ask him or before surgery. I retired. I am 60. I do not want to work anymore. Okay, I can cut more. Yes, I'm 30. I am resident in surgery. I would like to continue to develop my own career, and I need to have a very good reaction time to make decisions. Okay, so at that time, do not cut completely the ILF. You feel the difference? You think we know the anatomy? This year in Brain, the first international journal of neurology, blah, blah, 2024, we demonstrated the existence of a new fasciculus. That's crazy. With 4 different sublayers, the Arnold's bundles, not nerves, bundles. And it's very difficult to be sure about its real critical role in lexical retrieval. It's our hypothesis. But we are not sure. So that means that we do not know the anatomy. It's true for the reading, for the writing. For reading, we have understood we have to preserve the visual waveform area at the level of the left fusiform gyrus Dufault. No. There are 4 to 5 pathways bilaterally, thanks to the tapetum just in between. And when you start to think about 9 pathways around the visual waveform area, you have a chance to preserve the reading or not, and to know exactly where to put the threshold according to the wishes of the patient before surgery. So you have, first of all, to be a neuroscientist and to model the interactions within and between networks, and to play with this understanding in order to push more or less the resection according to the dynamics of the networks, not shown by DTI, which is rigid and which is not a function. How do you want to map with DTI the executive functions, the multitasking, the mental flexibility? Simply, you cannot. So you can ask the patient, which is operated on in a wake condition, to switch from one task to another one, or from one language to another one for bilingual patients. And then you will increase the cognitive demand, and then you will map the cognitive control, or not. It's à la carte. You have to preserve, of course, the visual pathway. If you cut the optic tract, including in so-called right non-dominant hemisphere, a patient will have an myopia. With that, he cannot drive, so it's not a normal life. So in order to better understand this concept of spatial awareness, by using DTI before and after surgery 20 years ago and publishing in Science, then we demonstrated that it was possible to avoid neglect by preserving the layer 2 of the superior longitudinal fasciculus in the so-called right non-dominant hemisphere. Perfect. But it was 20 years ago. We understood with experience and the feedback provided by the patient 20 years later that, in fact, they could have nonetheless some attentional disorders. So we know now that we could, or not, it's à la carte, preserve the cingulate bundle and the frontoparietal mesial structures connectivity in addition to the SLF2. And then you can play with the interactions between both networks in order to preserve the attentional processing regarding the visuospatial processing. Once again, I do not say that we have to do it in all patients. We have to apply this knowledge to the wishes of the patient before surgery. The right non-dominant waveform, what means? It's critical for non-verbal semantic cognition. If you need a high level of integration in your job, you have to preserve it. And finally, of course, speaking about the functions, then before to see the oncological results, but I know that at the end of the oncological results, you will say, how is it possible to achieve this kind of outcomes? Because the better understanding of the connectome. I'm giving you keys now to reproduce the same results. And the keys are not to think about the tumor, but to know the connectome, including regarding the behavior of the patient. Now I can start to predict if my patients after surgery can modulate a little bit the behavior like irritability, disinterest, and so on. So you can incorporate or not into the operating theater the recognition of emotion in front of you, thanks to emotion expressed by IOS. And then when you stimulate, the patient can say, for instance, happiness rather than sadness. And I will not insist about the fact that we model different levels of mentalizing empathy, the recognition of emotion, and the inference of intentions. I'm just a science Duffau. No. It's exactly what you are doing when you interact with others. Namely, without that, it's impossible to work. So you imagine the right eye far, which is not mapped in 95% of cases in the world today in 2024, is critical for cognition, executive control, emotions. But we do not care. Really? Are you sure that the patients are so well? I asked to my patient 20 years later, did you enjoy my life as human beings? And because the answer was almost, we increased the level by incorporating into the OR the possibility to self-evaluate. And you will tell me, so long to do so many tasks. No, 5 seconds. You move, this is a cat combined with a dog, because animals, you can speak. you showed that you understood. You self-evaluate about 6 if you want, 5 seconds. And you will switch now in another language for the next one. So you increase the cognitive demand or not if you are just monolingual. What means the non-dominant hemisphere? I never understood that. So in order to show the clinical implications, I compared myself to myself, specifically in the right so-called non-dominant hemisphere for surgery of low-grade glioma involving the insula. And you can see by yourself, when I was younger, of course, I had only 82% of return to work, which is not so bad. But by deciding suddenly to ask to all patients to be fully awake during the mapping and the cognitive monitoring, then suddenly the return to work was beyond 95%. But the extent of resistance is exactly the same. So I understood that it was critical to preserve the connectivity in the data. And to be more, objective, we did recently this year a meta-analysis and literature regarding low-grade and high-grade in the so-called right non-dominant hemisphere by comparing patients operated on under wake mapping versus under general anesthesia. And you can imagine, of course, the message everywhere in the world. If you take time to do a wake mapping in the right so-called non-dominant hemisphere, the results are better. And the standardization is the same. So why it was not done systematically? So the long-term functional and oncological outcomes unique in the literature. When I started, the survival was 6 years. It's not my opinion, it's objective. And the quality of life was not evaluated. I'm so happy because the patient is still alive, whatever the condition. So I did surgery in more than 1,000 patients with low-grade glioma located within so-called eloquent areas, not selected by other surgeons in 5 continents. Why? I have not understood, not yet. And I did reoperation in 1/3 of them. The results, mortality 0, less than 1% of severe permanent deficits. So you can operate within so-called eloquent areas under awake mapping with 99% reliability. This is the message. Not 5 to 10% of deficit acceptable, less than 0.5%. But also with preservation of the cognition in 86% of cases, plus 10% of improvement, which is unique in the literature simply because 99% of department of general surgery do not evaluate the cognition before and after surgery. Why? Why? 94% of return to work, which is unique in the literature. And of course, 80% of positive impact on epilepsy, which is just, of course, well known for all of us. So in order to show more accurately the oncological results, I selected IDH mutated patients. I selected 600 patients with a consecutive series, and we demonstrated for the first time, once again, but I insist about that because this is unique, this is possible. The survival is over 20 years and not reached. So that means that maybe I will show you in 5 years that you can have an improvement of the survival beyond 23 years. You can see that it was done there with extensive resections, of course, according to the connectome, but also with less than 10% of early adjuvant treatment, less than 2% of radiotherapy. The goal is to do chemoradiotherapy on patients. Why? Your goal, is it to apply a protocol which will change every 5 years or to help patients? If you irradiate a patient, and if 10 years later we are telling, oh, finally it's not good for cognition, how do you want to go backward? It's impossible. So we decided since the beginning to do prospectively this study by collecting prospectively cases. And you can tell me, oh, yes, but it depends if it's an astrocytoma, oligodendroglioma, and so on. Of course, it's better to have an oligodendroglioma. In astrocytoma, median survival for the first time in the literature over 15 years. And oligodendroglioma, I don't know, not reached probably 30 years. I will tell you in 10 years before my retirement. And of course, if you have an impact, whatever the molecular pattern of the tumor, by surgery per se, it's related to the extent of resection. And then you will tell me where to stop according to the connectome. The first part of my talk, if we have not understood the brain, never DTI will give you this kind of information. And this is the reason why I started 20 years ago to do supratotal resection, because I know where to stop, because the brain told me, stop. So in this, let's say, paper, we use propensity score matching analysis, and we definitely demonstrated that whatever the molecular profile, if you do, of course, a total resection is better than subtotal or partial, but if you do a supratotal resection, it's better than total resection. Yes, but you will probably induce a cognitive decline, Duffau, by removing the brain itself. No, we published for the first time in the literature this year in brain about 400 patients with low-grade glioma, comparison between total versus supratotal resection. And finally, the results of the cognitions are similar. How is it possible, Duffau? Because I stopped according to the functional boundaries of this patient at that time. So, do awake surgery with intraoperative cognitive monitoring. Yes, but are you sure that the patient will continue to enjoy a normal life after 5 to 10 years? Yes. For the first time in the literature, we're demonstrating a long-lasting preservation of an active life, including upon to work, approximately 15 years, because you started to have patients with astrocytoma with a recurrence and a decline of the functionality. But after 15 years, despite the non-selection of the vast majority of patients not operated on in another department. Oh, there is a bias in your series, Duffau. Yes, patients not selected for surgery. So you can imagine if I had to operate a very small and easy prefrontal tumor, I will not do under general anesthesia. I will do under local anesthesia by amputating the lobe itself according to the functional boundaries. And then my patients will live 30 years. So the question is how to continue to improve long-term onco-functional results, because I cannot cure that. So the goal was, first of all, to arrive earlier and to say we started to operate patients with incidental discovery. And suddenly, all patients almost returned to their employment, 97% of them, and we changed radically natural history of the disease with more than 93% of survival after 10 years. It's true in Montpellier, it's true in San Francisco, it's true in Italy, it's true in Canada. But even if you do supratotorization, after 20 years, in all cases, I have seen a regrowth of the flare hypersignal around. I cannot cure them. So how to deal with that? To do reoperation. Yes, but that means that you have to amputate more brain before. Yes, of course. But you said that you stop according to the functional boundaries. Yes, but the connectome changed in the meantime, the dynamics of the brain. You mean that the map is different in the same patients over years? Yes. And to understand that, we have to understand, so the interactions between hemispheres, so I don't know definitely what means non-dominant hemisphere, knowing that if you operate a patient with an insular glioma, for instance, then in the contralateral side, we demonstrated that there was in adult an increase of the volume of the other insula in the other side. So an increase of the connectivity. So of course you can induce SMA syndrome if the patient told you I am not a pianist, a surgeon, or a sportsman with high level, okay, as you want. And of course, It was very exciting by doing fMRI before and after surgery to better understand mechanisms of reorganization explaining this recovery, even if not perfect. And it's exactly what we did by demonstrating the modification between both hemispheres in their connectivity during the transitory SMA syndrome and after the recovery. So we used this reorganization to reoperate patients. First surgery within the so-called primary motor cortex of the hand, the knob of the hand. Okay, I left tumor voluntarily. I came back 5 years later. Why? Because in the meantime, no chemo, no radiotherapy, because reduction of the volume and patient enjoying a normal life. Okay. During the second surgery, you can see that the positive sides during the first surgery disappeared in the same patient. Why? Because, of course, the tumor regrew and the patient adapted, brain reorganized while enjoying perfect normal life. And during the second surgery, I removed more brain invaded by the tumor by preserving the connectivity in the DAP. And it's true in the knob of the hand, the previous patient was a guitarist. Even after surgery, of course. It's true within so-called Wernicke's area, which does not exist. It's true within Broca's area, but also by doing 10 years later, bilateral frontal lobectomy in patients still able to work, take care of children, drive, and so on and so on. Oh, there is no limit to the plasticity. Of course, there are some limits. The connectivity in the data. So in order to better understand the pattern of reorganization, first of all, at the cortical level, we published in Brain for the first time past year, the map during the first surgery and the map during the second surgery about hundreds of patients. And the reorganization in order to try to anticipate when to reoperate a patient when you continue to follow them for 25 years. The first patient I operated on was 28 years ago. She's still a nurse. So we have to understand this pattern of reorganization in order to reoperate 3 times. And in this subseries, the median survival is only 18 years. But by including grade 2 and 3 IDH mutated, yes, you can live with a median survival almost 20 years by preserving quality of life, even when you have a high-grade glioma, a glioblastoma, of course, but grade 3, if you did each time a more extensive resection of the brain self-invaded by the tumor. What means a tumor mass? We are speaking about diffuse glioma. Yes, but when you reoperate before, the quality of life is not so good. Of course it is. We did systematically a cognitive assessment, and you can see that the scores are the same after second surgery, and again, 94% of return to work, thanks to brain plastic mechanisms. So to operate the brain, you have to understand the limitation of neuroplasticity. And to help you, of course, we published this kind of atlas in the MNI template. I try very, very frequently to explain to neurosurgeons that when they would like to remove a tumor mass, which does not exist, they are under microscope, which is dangerous. They are removing the insular tumor. They are happy. And they feel in the depth, there is still a residue of the tumor. Of course, this is a diffuse glioma. You have residue up to 2 centimeters around. But they would like to remove 3 more millimeters. And they're telling just 3 more millimeters. No, it's a disconnection of 1/3 of the hemisphere. You can see the I-5. I'm sure that the vast majority of surgeons will say, what means I-5? How do you want to operate the insula if you do not know what means I-5? And for 3 millimeters, due to the brain shift, it's nothing acceptable. You disconnect 1/3 of the hemisphere, and you are telling my results are not the same. Dufault is lying. But it's a pity. You cannot operate the brain like this. And radiotherapists cannot irradiate the brain after you too early. Otherwise, they will irradiate the connectivity, the limitation of neuroplasticity. So This is the reason why, remember, only 1% of my patients benefited from early radiotherapy. Because radiotherapists will tell you, oh, we never demonstrated that the survival is longer. We demonstrated thanks to surgery. But they demonstrated that the progression-free survival is better. We do not care. Patients do not care. What they want is to live longer and better. And PFS increased does not mean that the survival increased. This is the proof in this trial by Van den Bent. PFS increased, but the survival was the same, and the quality of life was worse, related to late effect, cognitive effect of radiotherapy. So never use too early radiotherapy. Please come back, induce plasticity. Please use chemotherapy when you cannot re-operate because the diffusion within the white matter tract and in fine, ask to the patient to be irradiated. It's exactly what I did today. I proposed to one of my patients to be irradiated. I myself irradiated 22 years after my first surgery by telling, of course, I hate early radiotherapy and I know why. I demonstrated why. 22 years later, it's not early radiotherapy. Now we are so happy to keep this ACE in order to control the disease, I hope a few years more, and then to live more than 25 years. And after that, I don't know, because I cannot cure them. It's not only in Montpellier. You can see the new publications on this field. If radiotherapists are honest by doing cognitive assessment within the 5 years following surgery, you are half of patients with a decline of cognitive and or emotion processing. So please use chemotherapy when you cannot reoperate due to the limitation of neuroplasticity and the invasion of the white matter tract after 10, 15, 20 years. And we demonstrated this year, thanks to our neuro-oncologists, that you have no negative impact on cognition, conversely to radiotherapy. But if you can reoperate, please do it. We published just 2 months ago, for the first time in the literature, patients who have been operated on for low-grade glioma 4 to 5 times, not because of rapid recurrence, but 20 years later, with a normal life in the meantime, no radiotherapy, still active, working. And now, once again, you can start to use radiotherapy, even if there were some foci or malignant transformation in the middle of the tumor. The WHO classification never understood what is a glioma. A glioma is heterogeneous. So if you have just a focus of grade 3 or 4 in the middle, and you did a total resection according to post-operative MRI, or of course, a supratotal resection according to the connectome, the survival at 5 years is over 95% without adjuvant treatment. Example, enhancement, it was in 2002, grade 3 at that time. I did a second surgery 7 years ago. It was a grade 2, no chemotherapy, no radiotherapy. Patient just starting chemotherapy now, 23 years later. And it's true, even if the tumor is very big. We published this whole series in the literature with patients harboring low-grade glioma of more than 100 cc. And the quality of life is the same. And you can change radically in natural history of the disease, whatever the grade, 2 or 3, because of course, if the tumor is big, in the vast majority of cases, you started to have some foci of malignant transformation in the middle. But what is neglected in the literature is the real quality of life of patients, the return to work between 20 and 50. We did a meta-analysis 2 years ago, only less than 20 studies which tried to better understand if patients return to work. That's crazy. About sexuality, between 20 and 50, it could be important. Only 3 studies in the literature with thousands of papers about the molecular pattern of the tumor patch. We're speaking about human beings. 3 studies, 2 from Montpellier, That's it. And everyone is telling my patients I want. Are you sure? Speaking about creativity, I will have a paper accepted in Journal of Neurosurgery about not only musicians, but also architects, writers, and so on. In all cases, they were able to return to their work as an artist. But sometimes, as you can see, you can change the style of the patient. And I have no time to insist about that, but I started to understand 20 years later that it was related to an imbalance I created by doing this very extensive frontal lobectomy in the so-called right non-dominant hemisphere between the deformant network and the executive control network due to the modification of the salience network in the middle. No time to insist, but I mean, we can start to predict even if you can change the creativity of a human being. You will tell me so many things. Yes, but the brain is complex. We are brain surgeons. So to help younger people, we published this kind of atlases, unique in the literature, with the real function of the white matter tract. So many guys are telling, oh, you have the last DTI atlas. But it's not a function. Are you sure the function for you, Dufault? Of course, I stimulated the white matter tracts with cognitive disturbances induced by the stimulation in hundreds of patients. And it was published in the MNI template. Definitely, we understood that in order to recover after this kind of surgery, but also to compensate the slow growth rate of low-grade glioma, the brain needs integration between different networks and not just one area corresponding to one function. Forget it. The brain processing is based on the perpetual succession of new equilibrium states. Your meta network changed in comparison with 1 hour ago before this talk. And by understanding that, you can start to predict how your patient will recover, not avoiding aphasia hemiplegia, but really returning to an active life in more than 90% cases. You can predict that in consultation during the first meeting of the patient. Of course, to help you, you can use at that time fMRI also not at the individual level, but understanding the mechanisms of hundreds of patients. And we published recently this paper also in Brain this year by combining stimulation data and fMRI and DTI, but as a research tool. Then we can start to predict what will be the extent of resection before to go to the OR at the individual level. Then you can predict if the patient will return to normal life, including to work. Then you can predict into the operating theater where to stop according to the wishes of the human being in front of you before surgery. Then you can start to predict how the patient will recover according to the postoperative cognitive rehabilitation because you will elaborate individualized program of functional rehabilitation. Then you can start to predict when to reoperate. 3 years, 4 years, 7 years after, for instance, a relapse following first surgery within the insula for low-grade glioma. Then we would like now to induce more plasticity and to avoid the negative plasticity in order to focus on the positive one and to sometimes switch from one pattern of reorganization to another one, for instance, perilesional to contralateral. This is the concept of metaplasticity, but I will not too much insist today because I have now to conclude and to tell you that, of course, never I allowed what we call evidence-based medicine based on protocols, because protocols are just helpful for 5 years. My patients are living more than 20 years. They have seen 5 different classifications of the WHO. They have seen 5 different protocols. We have to operate earlier. We have finally to irradiate. Oops, no, finally we had to give vorazidenib now. Please be reasonable. We are speaking about human beings. So how do you want to elaborate personalized management? Everyone is speaking about that without understanding the mechanisms of brain plasticity. And you cannot understand these mechanisms if we do not know the anatomy of the brain. You see, it's full of common sense. You sure that young oncologists and especially radiotherapists know the functional anatomy of the brain when they radiate? So, of course, according to that, you can elaborate 5 to 10 years in advance a strategy by anticipating what will happen according to the concept of connectomic neuro-oncology, which was, remember, my first slide today. And I hope that in the meantime, you have better understood what I would like to mean. So the last slide is just an evidence. Do you want just to remove a brain tumor as a technician and trying to make this tumor visible into the operating theater, which is, of course, impossible because it's a diffuse glioma? Or do you want to manage a human being in front of you for the next 20 to 30 years by preserving also the quality of life? Now, I demonstrated that it was possible to achieve these results. So now it's your responsibility not only to reproduce the same results, but to go beyond, because my limitations is that I was not able to cure them. So just do it. Thank you so much.
Thank you so much, Professor Duffau. Wonderful, wonderful webinar. And I think there's going to be some questions here that we can provide you. A couple of things come to mind. Obviously, this is a tour de force in terms of awake mapping using intraoperative connectomic analyses in your decision-making for surgery. There's a movement now where connectomics are trying to be integrated in some of the imaging modalities that are used. And, you are actually discovering the connectome in the operating room and finding it. Others are trying to distill it into an imaging modality. What are your thoughts on that?
I would like to see the results. Show me one paper in the literature with a median survival about 20 years, with preservation of quality of life. Once again, I would like to show again this slide. The best results ever published in the literature now, you have seen, have been obtained without technology. And I don't know how to explain that. What they are selling in the intraoperative setting by showing beautiful imaging is not a function. This is just an imagination of technicians. So I would like to see the results. Do you want to use technology for fun, for marketing, for money, or to help patients? So now, because fMRI is existing since 20 years, I would like to see the results, please, with 1,000 patients. And then you will convince me.
Maria, did you want to provide some questions?
The question? Yes, so there are 3 questions, I believe, in the Q&A box, sir. First of all, thank you very much for the very elaborate and wonderful lecture and for all the results and all those things that will help everyone in their practice. Sir, here in the question in the Q&A, I can find there are 3 questions. Recently, there is a question from Dr. Omar Alvar, who is asking what type of stimulation do you use, and bipolar or unipolar?
I do not care, because the most important for me is not to stimulate. The most important is the real-time intraoperative cognitive monitoring. So, because I was trained by George Hirschman almost 30 years ago, and because he was applying the concept of Penfield, I continue to use 60 hertz, 1 to 3 milliamps bipolar and biphasic stimulation, and that's it. But that works. I do not care.
Thank you very much. So there's another question from Dr. Arman from Dhaka, Bangladesh. If there's a tumor in the motor cortex, how do we resect without creating any deficit? Kindly share some tips and tricks.
Yes, to ask to the brain to help you by reorganizing itself, as I demonstrated on this slide, for instance. If I cannot remove completely the knob of the hand, 40, 49, 41, then I will come back a few years later, and you see that I can remove the knob of the hand, while in the meantime, the brain reshaped. So it's very easy to understand that we have to trust, believe on the magic of the brain, and of course, to better understand, of course, the mechanisms. And to better understand the mechanisms, yes, fMRI can be helpful. You can see on the left that the first fMRI demonstrated an activation within the precentral sulcus, and 5 years later in the central sulcus with more recruitment of the contralateral hemisphere, so showing a reorganization of the network. And then suddenly I have no trick into the OR. I'm just removing the area not critical anymore. But by preserving the connectivity, you can see in the depth, the 15, 10, 12, 13, if you cut that, suddenly the patient will start to move. My trick also, if you are speaking about tricks, is that I do not coagulate, except maybe the cortical surface to start after the negative mapping. Okay. But in the depth, I will do a subial dissection. Yes, I know you will say, oh, it's very easy in low-grade glioma. It's not possible in glioblastoma. This week, I had colleagues, visitors, as every week since 20 years, coming from China, from America, from Europe, and so on. I operated on glioblastoma, 130 cc, with beautiful enhancements everywhere. Never I coagulated in the depth because I did not remove the enhancement, of course. I removed the lobe around the enhancement. And what happened? Nothing. The patient is living today, 3 days after surgery. So do not coagulate. Otherwise, if you take microscope and if you would like to see everything black in the depth in the end, you have to be aware about the fact that you disconnected at that time 1/3 of the hemisphere. And many of your patients will not have a perfect cognitive scores following surgery. You will tell me we are speaking also about glioblastoma. Yes, this patient had a cognitive assessment this morning, 3 days after the resection of 100 cc, and I removed 95% of the flare. And the cognitive scores are better now in comparison with 3 days ago. All my patients will benefit from objective neuropsychological assessment before and after surgery. Why not in glioblastoma?
Professor Duffau, we're running a little bit low on time, but I do want to make sure we ask one important question. This is from Brian Mott. So in the US, about 6 months ago, the FDA approved vorasidenib for IDH mutated grade 2 gliomas. How is that now impacting your intraoperative decision-making and approach for tumors? Are you still pushing the envelope, or with certain tumors that may be more difficult to take out, or are you now relying on potential treatment with the vorasidenib?
How do you want to rely on vorasidenib? Because the median follow-up is less than 2 years. I'm speaking about patients living in more than 20 years. How can you extrapolate what could happen in these patients in 20 years? Second, 20% of patients with vorasidenib have no tumor control, 20%. I know the reasons very well because I have the slides from the snow recently. Third, some of our patients, when we use vorasidenib not immediately after surgery, but 15 years later, for instance, had a sudden explosion of the tumor. Fourth, I can give this opportunity for patients to live longer and better. So why to change by using a pill with so few follow-up suddenly because it's new with $25,000 per month, maybe. Because I'm not so expensive.
Very good. Maria, do you want to provide a few thoughts here in closing? You're on mute. Yeah.
Thank you very, very much, sir, for this very insightful talk and for all the topics that you have touched so far. You have been really inspiring us all, and thank you very much for all the tips and tricks that you have shared and for the Q&A. And I believe that this will help everyone so much in each and every way. And I've been just processing everything that you have taught to us, and that will be very helpful for us. And I think we are reaching out so many people through your webinar, through this virtual talk. So I think your message has been echoed at every part of the world right now. So thank you very, very much for this very insightful talk, and thank you so much, Professor Costas, for this for agreeing to this wonderful webinar series. It's an honor to be a part of this thing. So these are one of my thoughts, and I believe that this will help everyone to understand, have a deeper insight, and playing more with what we have, with the technology that we have, and they say that it needs someone to have enough knowledge to use a tool. So a tool should be used with a lot of wisdom and knowledge. So you have very nicely mentioned about different technologies as well, and your thoughts about all these things. So thank you very much.
Thank you very much, Professor
Thank
Duffau.
you for
Really
the
appreciate it.
invitation.
Yeah, thank you so much. Have a great day and weekend, everybody.
Goodbye. Thank you.
Goodbye. Bonjour.